Hello guys, hope you're doing fine. And this is ᴰᴇᴏ, and today we're going to discuss Tetralogy of Fallot, or Fallot's Tetralogy, lol. So moving on to the next slide, we'll discuss the outline. In the outline, we're going to repeat, obviously, the same: introduction, etiology, pathophysiology, signs, symptoms, complications, diagnosis, and in the end, we'll discuss some treatment. Introduction to Tetralogy of Fallot. It is the most common cyanotic congenital heart defect, CHD. Now, the thing is that there are cyanotic as well as non-cyanotic congenital heart defects. But this one, Tetralogy of Fallot, is a cyanotic congenital heart defect. And the thing is, it is the most common cyanotic congenital heart defect. It is characterized by 4 characteristic defects. Alright? 4 characteristic defects underlie Tetralogy of Fallot. And I learned them by the mnemonic prove, and it is written in your USMLE first aid, I guess. Prove. The mnemonic is prove. P for pulmonary artery stenosis, R for right ventricular hypertrophy, O for overriding of aorta, which is also known as straddling or juxtaposition of aorta, and in the end we have the V for ventricular septal defect. So these are the 4 main characteristic distinguishing features of Tetralogy of Fallot. And this was the introduction of Tetralogy of Fallot. Now we shall move on to the next slide. We'll discuss some etiology now. Tetralogy of Fallot has multifactorial inheritance. Alright. Most of the times it is associated with Down syndrome, people with Down syndrome. When you check the echocardiography and stuff like that, you'll notice that there are cardiac defects, and if you look further, you'll find Tetralogy of Fallot, right? And in most cases, not all, but most cases, fetal alcohol syndrome, when the baby is developing in the womb and the mother is taking excessive quantities of alcohol, the most likely defect in the cardiac region of the fetus will be Tetralogy of Fallot. Charge syndrome. Charge is a mnemonic, and I won't go into the details, but it is a syndrome. It is also associated with the DGeorge 22q11.2 deletion syndrome, .2 or 0.2 deletion syndrome. This is also a genetic disease. This deletion of 22q11.2 something. And fetus abortion is associated with Tetralogy of Fallot. Diabetes, alright. And during old age pregnancy, if the mother is infected with rubella, there is a high chance that the fetus will have Tetralogy of Fallot. Now there are, as I said, it has a multifactorial inheritance. Therefore, there is not one single gene that is responsible for all the stuff that is happening inside your heart. So there are multiple mutations in multiple genes. For example, we have cardiac specifying homobox gene CSX-NKX2.5 and genes in your Notch signaling pathways such as the Notch1 gene and a couple of other genes. If they are mutated, alright, the fetus would have Tetralogy of Fallot. So these are just the 2 genes of multiple others, alright, that if they get mutated, they would develop into Tetralogy of Fallot. And this was about the etiology. We'll move on to the next slide now. Pathophysiology of Tetralogy of Fallot is diffuse, I guess. we have, now the thing is that in order to learn the pathophysiology, you need to know the embryology, the embryological development of your heart, alright, and the associated vessels. And without that, you won't be able to grasp the concept of pathophysiology. So I won't be explaining the stuff here, because this is not an embryology class. This is a pathophysiology or pathology, whatever you can say. This is not your embryological lecture. So in order to learn this or grasp a concept of this, you need to have sufficient knowledge of the embryological development of your cardiovascular system. So supposing that you know that, we'll learn the pathophysiology. So we have hypertrophy of the subpulmonary muscles, and this leads to narrowing of the right ventricular outflow tract, RVOT. Now this can happen at the pulmonary valve, and in this case it will be known as pulmonary valvular stenosis, and it can happen below the pulmonary valve. In this case it would be known as the pulmonary infundibular stenosis. Alright, so we have muscular hypertrophy of the subpulmonary muscle, alright, and then there is narrowing of the right ventricular outflow tract, and if it happens at the pulmonary valve, we call it pulmonary valvular stenosis, and if it happens below the pulmonary valve, we'll call it the pulmonary infundibular stenosis. Another thing to mention here is that the pulmonary blood flow is dependent on a patent ductus arteriosus. Alright, since there is stenosis of your pulmonary trunk or pulmonary arteries, the pulmonary blood cannot flow from them, or won't be able to flow as much as it would do in a normal heart. So what happens is that the presence of a patent means open, patent ductus arteriosus is essential for the flow of the blood through the circulation. Another thing I would like to mention is that incomplete closure of the membranous septum would lead to ventricular septal defect. Obviously, when there's an ostium that fails to close, we would have ventricular septal defect if that hole is between two ventricles. Abnormal development of the spiral septum, this would lead to dextroposition, straddling, or overriding aorta. Now, as I mentioned before, you need to have sufficient knowledge of the septas, the ostia, and everything else associated with embryological development of the cardiovascular system in order to grasp the pathophysiology of Tetralogy of Fallot. Since the blood is bypassing the lungs, there won't be any oxygenation, and the aortic blood will be unoxygenated. That is why in later slides you would learn that there is cyanosis, because the blood is deoxygenated. Right? So if there is unequal partitioning of the outflow tract by the truncoconal ridges, which are also known as the bulbar ridges, there would be stenosis of the pulmonary trunk. Alright, and the pulmonary trunk would be small, and this would eventually lead to right to left shunting of the blood. Alright, so again, if the neural crest cells, their migration is abnormal, there would be skewed development of the aorticopulmonary septum. Alright, so these all All of these malformations, they are related to the Tetralogy of Fallot. Now, the thing is that in order to grasp this, as I have mentioned multiple times, you need to have a sufficient understanding of the embryological development of your cardiovascular system. And without that, you won't be able to grasp the concept. Moving on, moving on, the thing is, the blood would, fill the left ventricle, and it would move via the VSD, the ventricular septal defect, into the right ventricle. Okay, so instead, what happens in a normal heart is that you have the right ventricle. When it pumps, the blood goes into the pulmonary trunk, gets oxygenated into via the lungs, and then comes back into your heart, into the left atrium, and then from the left atrium it goes into the left ventricle, and from the left ventricle we have aorta, which takes that oxygenated blood and provides it to the entire body. But in case of Tetralogy of Fallot, what happens is that since there's a ventricular septal defect, an ostium, a passage between the two ventricles, what happens is that the left ventricle blood, the blood in your left ventricle, or a patient with Tetralogy of Fallot, the blood in their left ventricle would move via the VSD into the right ventricle. And since there's an overriding aorta, the blood from both these ventricles will move into the aorta. So there's mixing of blood. Alright, there's plentiful mixing of blood, and that mixed blood, and most of it is deoxygenated, it would move into the aorta and it would be supplied to the entire body, which would cause cyanosis, as we would learn in the next slides. So this is a general pathophysiology of Tetralogy of Fallot, of Fallot's tetralogy. And some minor malformations are that there's a right aortic arch, alright, and we have some aortic valve malformations, and we have left superior vena cava. So this concludes the pathophysiology of Tetralogy of Fallot, and moving on to the next slide, we would discuss some signs, symptoms, and complications. Signs, symptoms, and complications of Tetralogy of Fallot, like the pathophysiology, are diffuse. By diffuse, I mean that they are very obscure in nature. And yes, the clinical consequences depend primarily on the severity of the pulmonary stenosis. Tetralogy of Fallot is measured in severity by the severity of the pulmonary stenosis. So if the severity of the pulmonary stenosis is high, the disease is severe. Alright, so we have pulmonary atresia, and it is a very severe form of Tetralogy of Fallot, because most of the time in Tetralogy of Fallot there is stenosis, a partial closure of the pulmonary trunk. But in severe cases we have pulmonary atresia, and this atresia is very devastating for the baby, obviously. We have ⴠⴜᴛᴏ, which is a boot-shaped heart and is visible on a chest x-ray. Normally we don't do x-rays to diagnose defects in the heart. For example, the Tetralogy of Fallot, we use ultrasounds. But if we view the chest x-ray, CXR obviously, we would find a boot-shaped heart, because there is right ventricular hypertrophy, alright, and since the right ventricle is enlarged, we would have a boot-shaped heart, alright. This is known as ⴠⴜᴛᴏ Sabah, I can't pronounce that right, sorry for that. Cyanosis of lips and fingernails, and we call that thing a blue baby. A blue baby because of the blue discoloration of the skin. So yeah, since there is mixing of the oxygenated and the deoxygenated blood, and since most of it is deoxygenated, and if deoxygenated blood is supplied to your body, your skin gets bluish discoloration happens, and this condition is known as cyanosis. Now, most of the times the cyanosis is not consistent. Alright, it happens in certain conditions most of the times, and these conditions are known as TET spells, and these mostly happen when the baby is either crying or is breastfeeding. Alright, well, baby is feeding, obviously. So these are spells, certain episodes of cyanosis, which are not continuous, but they happen when the baby is crying. We have ostium secundum or atrial septal defects. Alright, we have atrioventricular septal defects. We have endocardial cushion defects. Alright, and these are all associated with Tetralogy of Fallot. We have dyspnea, obviously, because there's less supply of oxygenated blood. So there's dyspnea because the tissues, they can't get the proper oxygen. Tetralogy of Fallot is sometimes associated with bacterial endocarditis. Endocarditis is the inflammation of the endocardium. Alright, and it is bacterial in nature, so bacterial endocarditis. Tetralogy of Fallot is also associated with brain abscesses. Alright, you would find brain abscess in people with Tetralogy of Fallot. And yeah, there's hypertension in your right ventricle. Why? Because the pulmonary trunk is stenosed. The right ventricular outflow tract is stenosed. It's partially closed, and therefore your total peripheral resistance increases, due to which there is high pressure, blood pressure in your right ventricle. The next thing we find in Tetralogy of Fallot is right axis deviation on electrocardiography or ECG. What is right axis deviation? It's topic of ECG, but yeah, you would find right axis deviation on ECG. We have sometimes agitation, mood swings, heart murmurs, irregular heart rhythms, limping of the baby. The baby limps and falls and walks staggerly. And we have loss of consciousness sometimes during TET spells. And these are extreme cases. The loss of consciousness, limping, etc. We would have polycythemia, obviously, as an augmentative mechanism to cope with low oxygen levels. And babies with Tetralogy of Fallot, sometimes they develop attention deficit hyperactivity disorder, ADHD, and increased total peripheral resistance, as I mentioned earlier. Now, if there is pulmonary atresia, or the disease is progressing towards pulmonary atresia, we would have complete blockage of your pulmonary trunk, and this would lead to heart failure because of increased total peripheral resistance, very high total peripheral resistance, and hypertension in your right ventricle. Alright, so we would have a right side heart failure. We would have dilated cardiomyopathy. We can find dysphagia in babies with Tetralogy of Fallot, and since there's dysphagia, they can't eat properly, they can't eat properly. The babies would have abnormal weight, less weight, obviously they would fail to gain weight, and one thing that is very prominent in people with tetralogy of Fallot, some people, is the clubbing of fingers and toes. So all of this was a general overview of the signs, symptoms, and complications of tetralogy of Fallot. Now we would move on to the next slide. Diagnosis of tetralogy of Fallot is very straightforward. Ultrasound. So when the ultrasound is of your heart or the area around the heart, we call it an angiocardiography. Alright. An improved or maybe different variant of ultrasound, which is known as a color Doppler ultrasound, is used to measure the degree of stenosis, and this can help us in diagnosing other malformations as well, so we can have a better understanding of the disease of the patient. Sometimes if there is not enough information with these two tests, we can do cardiac catheterization as well to diagnose tetralogy of Fallot. So yeah, it was pretty straightforward. Moving on to the next slide. Treatment of tetralogy of Fallot. So tetralogy of Fallot is a very devastating disease if it is not treated, alright? But if it is treated, and it is treated, it is treatable, it has an excellent post-treatment prognosis. When surgery is successful, the average life expectancy increases from only 3 to 4 years, which is like nothing, to 50 or more years. Alright? If the baby is weak or very small in age, like maybe 15 days or a month, you can't do the operation that quickly. So what they do is they place a temporary shunt temporarily. They place a temporary shunt. There's surgical placement of a temporary shunt, and when the baby is 2 months older or even more, they do the open heart, the proper surgery, which is the gold standard for tetralogy of Fallot. What they do in the surgery is that they open the pulmonary stenosis. Yeah, they maybe insert a shunt or something like that, and they close the septal defect, the ostium which was formed between the two ventricles, and they reconstruct, alright, the right ventricular outflow tract, and there is proper alignment of the right ventricular outflow tract into the pulmonary trunk. And sometimes before treatment, we can place the baby in a squatting position when there is a TET spell. This would decrease the total peripheral resistance, alright, and maybe reverse the shunt to a little extent, and the cyanosis would drop sometimes. And we use beta blockers such as propranolol and oxygen therapy to relieve TET spells. So yeah, the treatment is very effective. Excellent prognosis, excellent treatment, and they can live a normal life. There is sometimes need of a reoperation, sorry for that, for the redundance. There's need sometimes, not all the times, but sometimes there's a need of a reoperation. So yeah, this was all about the treatment of tetralogy of Fallot, and thank you for watching. I hope that you would have gotten in your heads the concept of tetralogy of Fallot by now. In case you can't absorb one fact or one concept of tetralogy of Fallot, you should comment in the comment section. If you like this video, please subscribe, consider liking and commenting, whatever you want, and it would immensely help this channel grow. And thank you all. Bye.